The patient with a blood disorder. Normal blood. Oral soft tissue changes, lowered resistance to infection, and bleeding tendencies are major factors to be considered for a patient with a blood disorder. Oral manifestations of blood disorders are generally exaggerated in the presence of dental biofilm and local predisposing factors. The composition of blood. It is composed of 45% formed elements and 55% fluid termed plasma. The 45% formed elements consist of 44% erythrocytes, also known as red blood cells or corpuscles, and 1% leukocytes, and that's also known as white blood cells and platelets. Hematocrit, a test commonly used in health examinations. It indicates the amount of blood cells present in a sample of blood expressed as a percentage. The origin of blood cells. Adult blood cells originate in bone marrow. Hemocytoblasts are the stem cells of origin. Erythrocytes and granulocytes leave the bone marrow as mature cells and enter the circulating blood. Agranulocytes, which consist of lymphocytes and monocytes, leave the bone marrow as immature cells and migrate to the lymphoid tissue to mature. Certain blood diseases and cancers are characterized by the predominance of immature cells. Plasma. Blood is a connective tissue, thus plasma has similar constituents to that of connective tissue fluid. Plasma is composed of 90% water. Plasma proteins make up the other 10% and include albumin, which functions to maintain tissue fluid balance within the vascular system, gamma globulins, which circulating antibodies essential to the immune system, beta globulin, these aid in the transport of hormones, metallic ions, and lipids, and fibrinogen and prothrombin, which is essential for the blood clotting. Inorganic salts include sodium, potassium, calcium bicarbonate, and chloride. Gases include dissolved oxygen, carbon dioxide, and nitrogen. Substances being transported include hormone, nutrients, waste products, and enzymes. If either plasma or whole blood is allowed to clot, the remaining fluid devoid of clotting factors is termed serum. Now we're going to talk about red blood cells, which are also known as erythrocytes. The description of red blood cells. Red blood cells are more properly termed corpuscles because they have no nuclei. They are flexible bioconcave disc containing hemoglobin, which can change shape as they pass through small capillaries. The function of red blood cells. It transports hemoglobin, which facilitates the transport of oxygen to cells in the form of oxyhemoglobin and waste carbon dioxide from the cells in the form of carbonimohemoglobin. Carbonimohemoglobin. That's difficult to say. The hemoglobin of red blood cells. Hemoglobin is the iron-containing protein in red blood cells. It's measured in grams per 100 milliliters. Normal values range from 12 to 17.5, depending on your gender. Values below normal reflect an anemic state. Pathologic conditions may result when values increase above normal. Okay, now we're going to go on to white blood cells, also known as leukocytes. So there's types of leukocytes. White blood cells are divided into two general groups, the granulocytes and then the agranulocytes. Granulocytes have granules in the cytoplasm, whereas agranulocytes do not. They are further subdivided into the following categories. So granulocytes contain neutrophils, eosinophils, and basophils. Agranulocytes contain lymphocytes and monocytes. The function of white blood cells. Phagocytic, immunologic, and other functions related to the inflammatory process in the connective tissue. Blood functions as a transport medium for the white cells as they pass to areas in the connective tissue where they are needed. They pass through the walls at the terminal ends of capillaries and into the connective tissue. Numbers and proportions in the blood maintain a constant level in health. Differential cell count of white blood cells is used in the detection and monitoring of disease states. Increases and decreases of each cell type can be associated with certain conditions. A large number of cells will migrate into the area of injury, and neutrophils arrive first and are active in phagocytosis of foreign materials and microorganisms. Okay, let's talk about agranulocytes. So lymphocytes, small round cells with a large round nucleus surrounded with a narrow rim of cytoplasm. They can move back and forth between the vessels and the extravascular tissues. They're capable of reverting to blast-like cells of origin and then multiplying as the immunologic needs arise. Then monocytes, large cells with a bean-shaped or indented nucleus, actively phagocytic, and connective tissue. Monocytes differentiate in macrophages, which are important in the immunologic process. Okay, granulocytes. So we're going to start with neutrophils. Neutrophils are also called polymorphonuclear leukocytes. The most numerous of white blood cells. Nucleus has 3 to 5 lobes connected by thin chromatin threads. Cells are round in circulation. They're amoeboid, move and change shape in the tissue and function of phagocytosis, part of the first line of defense of the body. Okay, eosinophils. These are 2-lobe nucleus and larger, coarser granules than those of neutrophils. Microscopically, the cells stain a distinct bright pink and are readily recognized. Few in number, increase during allergic conditions. And then basophils. Nucleus has a U or S form. Function to increase vascular permeability during inflammation so phagocytic cells can pass into the area. All right, we're going to move on to platelets, thrombocytes. Small, round, or oval-formed element without a nucleus, approximately 1/4 the size of a red blood cell. They're active in blood clotting mechanism. They're essential in the maintenance of the integrity of the blood capillaries by repairing them at the time of injury. And they participate in clot dissolution after healing. So now we're going to talk about anemia. Anemia is the reduction in the number and or the amount of hemoglobin present in red blood cells, such as that oxygen carrying capacity of the blood is diminished. So the classifications by cause of anemia. Caused by blood loss, acute, blood loss from trauma or disease, chronic, an internal lesion with constant slow bleeding, usually a gastrointestinal or gynecological origin. It can lead to a chronic loss of blood. Iron deficiency anemia may result. Another classification by cause of anemia is it being caused by increased hemolysis. Hemolysis means the destruction of red blood cells, also called hemolytic anemia, because it is attributed to cell destruction. It can be hereditary hemolytic disorders such as Sickle-Cell Disease, SCD, which belongs to the group of hereditary disorders called hemoglobinopathies. Acquired hemolytic disorders, those are drugs, infections, and certain physical and chemical agents may cause red cell destruction. Erythroblastosis fetalis, hemolytic disease of the newborn, a form of antibody-mediated anemia that occurs when an expectant mother is Rh positive and the fetus is Rh negative. Another classification by cause of anemia is being caused by diminished production of red blood cells. So nutritional deficiency, inadequate intake of necessary nutrients for erythrocyte production, defective absorption from the gastrointestinal tract. Examples, iron deficiency anemia, which may occur during pregnancy or during a growth spurt, celiac disease, which results from sensitivity to dietary gluten, and pernicious anemia, which results from a B12 vitamin absorption deficiency. Increased demand for nutrients, such as in a growth or pregnancy. Bone marrow failure. Aplastic anemia, it can be inherited, can occur without apparent cause or when the bone marrow is injured by medication, radiation, chemotherapy, or infection. In aplastic anemia, a combination of anemia, neutropenia, reduction in white blood cells, and thrombocytopenia, reduction in number of platelets occurs, which can lead to quantitative decreases in all cells formed in bone marrow. One should consult with the physician to determine if antibiotic premedication would be indicated. Another classification by cause of anemia of chronic diseases. It's the second most prevalent anemia after iron deficiency anemia. Anemia is associated with many chronic systemic diseases. Another classification by cause of anemia, caused by genetic blood disorders. Thalassemia is a diverse group of genetic blood disorders characterized by defects in the synthesis of normal hemoglobin. It typically affects people of Mediterranean, African, Middle Eastern, and Southeast Asian descent. The condition can range in severity from mild to life-threatening. The most severe form is beta thalassemia major, or also known as Cooley anemia. Blood counts are elevated and monitored for delayed wound healing. The treatment may require periodic and lifelong blood transfusions and chelation therapy, folic acid supplements, bone marrow transplant, hematopoietic stem cell transplantation has the potential to cure thalassemia. Novel treatments include gene therapy are under investigation. So clinical characteristics of anemia. When a patient's medical history shows the presence of anemia, certain general signs and symptoms may be identified through additional questions of clinical observation, including pale skin, nails, and buccal mucosa, weakness, malaise, and easily tired, dyspnea on slight exertion and faintness, brittle nails with loss of convexity referred to as spooning of the nails. Okay, next, iron deficiency anemia. Its characteristics. Iron deficiency anemia is a hypochromic microcytic anemia, which means that hemoglobin content is deficient. Hypochromic. Red blood cells are smaller than normal. Microcytic. Occurs more in younger than older people and more in females than in males. The diagnosis is by laboratory test that shows low hemoglobin and a reduced hematocrit value. The causes of iron deficiency anemia: low intake, malnutrition, vegans, chronic infections, decreased intestinal absorption, bariatric surgery or gastric bypass, celiac disease, inflammatory bowel disease, for example, Crohn's disease, increased body demand for iron over and above the daily intake, for example, during pregnancy, acute and chronic blood loss due to excessive menstrual flow, frequent blood donations, bleeding disorders, major surgery, and malignancy, internal bleeding due to gastrointestinal diseases such as ulcer or colon or stomach cancer, drugs, notably aspirin, hemorrhoids, and chronic alcoholism. Some signs and symptoms of iron deficiency anemia. General weakness, pallor, fatigue on slight exertion, decreased immune function and increased risk for infection, and oral findings. Pallor of the mucosa and gingiva, tongue changes, atrophic glossitis with loss of filiform papilla. In moderate and severe anemia, the tongue may be smooth and shiny. The patient may have burning, painful sensations or glossodynia. Secondary irritations to the thin atrophic mucosa may result from smoking, mechanical trauma, or hot and spicy foods. Angular cheilitis, increased risk of candidiasis. The therapy for iron deficiency anemia. Treatment of underlying cause to prevent further blood loss. Treated with oral ferrous iron tablets with vitamin C to aid absorption. To be taken on empty stomach for best absorption rates. Intravenous or IV iron therapy may be indicated for certain patients. Folic acid supplements may be indicated if there's an underlying folate deficiency. Nutritional counseling, recommended foods high in iron, liquid preparations, which are sometimes used for children, may stain the teeth. Administering the medicine by way of straw is advised. Okay, next we're going to talk about megaloblastic anemia. It is characterized by abnormally large red blood cells, many of which are oval-shaped, resulting from a deficiency of vitamin B12, cobalamin, and or folate, both necessary for the production of healthy red blood cells. Okay, so two types of megaloblastic anemia, pernicious anemia and then folate deficiency anemia. We're going to start with pernicious anemia. The etiologic factors. Considered an autoimmune disease causing atrophy of the gastric mucosa and destruction of stomach partial cells, intrinsic factor IF. Stomach parietal cells produce IF necessary for the absorption of vitamin B12. Deficiency of vitamin B12 can also be caused by malabsorption due to gastrointestinal disorders such as celiac disease and Crohn's disease. Inadequate intake due to dietary choices may cause deficiency, for example, strict vegans who do not consume animal sources. Chronic atrophic gastritis in older adults, or surgical removal of part or all of the stomach, gastric bypass. Decreased hydrochloric acid production, decreasing absorption. Long-term use of histamine receptor antagonists, proton pump inhibitors, or metformin. Age characteristics. Pernicious anemia is primarily a disease of adults and occurs with increasing frequency in those over the age of 60 years, although about half of patients are less than 60 years. Signs and symptoms. Fatigue and weakness, loss of appetite and weight loss, poor memory. Signs and symptoms, neurological involvement, sclerosis of the spinal cord, peripheral neuropathy, numbness and painful tingling in the hands and the feet, optical neuropathy, psychiatric manifestations, autonomic dysfunction, which may include dizziness or fainting on standing, orthostatic hypotension. Signs and symptoms of the oral findings, glossitis or Hunter glossitis, slick or bald tongue, loss of filiform papilla, and burning sensation with certain foods, sensitivity to hot and spicy foods. Gingiva and mucosa appear pale, atrophic, similar to vitamin B deficiency. And the treatment for pernicious anemia. For individuals with IF deficiency and or malabsorption, vitamin B12 is administered by injection daily until the condition is controlled. Once controlled, administration will continue monthly for life or until the underlying condition causing that deficiency is managed. For patients with inadequate IF production, oral supplementation of vitamin B12 is the treatment of choice. Vitamin B12 is only found in foods from animal sources and fortified foods. Good dietary sources of vitamin B12 are meat, clams, liver, fortified breakfast cereals, fish, poultry, milk, cheese, and eggs. Okay, folate deficiency anemia. Folate deficiency anemia has the same characteristics as pernicious anemia, except no clinical neurological changes are evident. The etiological factors: decreased intake, inadequate intake, severely restricted diets, and diets and fluids by such factors of poverty, food fetishism, or alcoholism, when the use of alcohol takes precedence over food. Impaired absorption. Individuals at risk of folate inadequacy: women of childbearing age, pregnant women, patients with alcohol dependence, individuals with malabsorption disorders, post-gastric surgery, celiac disease, and inflammatory bowel disease. Certain treatment regimens impair the utilization of folate, for example, cancer chemotherapy, rheumatoid arthritis, and medications such as methotrexate and Dilantin. Dietary food sources. In 1998, the Food and Drug Administration required fortification of cereals, breads, flours, pastas, and other grain products with folate. Dietary sources can be found later on. Fetal development. Women with inadequate folic acid intake are at an increased risk of having a baby with neural tube defects. Spina bifida. Myelomeningocele seal, a severe condition affecting the formation of nerves of the spinal column and resulting in infant paralysis. Moving on, sickle-cell disease. SCD is a hereditary form of hemolytic anemia resulting from a defective hemoglobin molecule. The name is derived from the crescent or sickle shape assumed by the erythrocyte when the defective hemoglobin loses oxygen. It is an autosomal recessive trait. Those with sickle cell trait demonstrate few symptoms unless placed under severe stress. The disease process of sickle cell disease. It occurs primarily in African American population and to a lesser degree in Hispanic, Middle Eastern, and Asian and Indian populations. The diagnosis. Prenatal diagnosis can be made with 100% accuracy and genetic counseling provided for parents. A simple blood test will detect SCD or sickle cell trait parental carrier. Newborn screening is mandatory in most states in the United States. The clinical course. Anemia. Lifespan of red blood cells is significantly reduced from a normal lifespan of approximately 90 to 120 days to about 10 to 15 days. Anemia appears within the first 6 months. Growth and development may be impaired during the early years. Increased susceptibility to severe bacterial infection, especially pneumococcal infections in young children. Multiple blood transfusion, putting patients at a high risk of bloodborne pathogens and hepatitis C. Vaso-occlusion. Mortality is primarily from repeated vaso-occlusions or blood vessel blockage resulting in infarction, organ damage, and or stroke. Progressive changes to blood vessels as a result of damage by the sickle-shaped red blood cells that result in the blood vessel blockage. Progressive organ damage resulting in a shortened life expectancy, with most patients only living into their 30s. Pain crisis, sickle cell crisis. Repeated episodes of unpredictable acute pain which results in hospitalization, often preceded by a viral or bacterial infection. Most people with SCD will experience progressive organ damage. Neurologic damage results in impaired cognition and hemorrhagic strokes. Cardiopulmonary damage impairs lung function and results in dilation of the left ventricle of the heart and heart murmurs. Hepatobiliary damage results in abnormal liver function and increase the likelihood of gallstones. Genitourinary damage may result in kidney failure. Skeletal damage may result in necrosis of the hips, shoulders, with a need for joint replacement. Skin effects may result in chronic ulcerations. Ocular damage in sickle cell anemia is a leading cause of blindness in patients of African ancestry. The treatment and diagnosis and management of sickle cell anemia. Supportive. Management of pain crisis remains challenging. Oxygen is a mainstream of treatment to minimize hypoxia. Pain relief without depressing breathing. Avoid substance abuse. Management of febrile episodes. Antibiotic for infectious disease to avoid sepsis. Prevention of sickling. Pharmacological therapy using a chemotherapy agent, hydroxyurea, to increase hemoglobin F factor decreases the permanent formation of sickle cells. Stem cell transplants may be an option. Use of prophylactic penicillin to prevent pneumonia and meningococcal sepsis. Regular blood transfusions. And chemotherapy and gene therapy show promise in the future. Okay, oral implications for sickle cell anemia. Radiographic findings. Coarse trabecular pattern appearing as a horizontal row between the teeth. Step ladder with large marrow spaces. Osteoporotic changes. Oral manifestations. Necrosis of the dental pulp. Osteomyelitis of the mandible. Enamel hypomineralization. Overgrowth of the facial bones resulting in protrusion of the maxillary causing malocclusion. Pilar buccomucosa, numb chin syndrome, mental nerve neuropathy, and facial and dental pain. The appointment management for sickle cell anemia. Thoroughly review the comprehensive medical history. Gather patient information regarding related complications specific to organ damage and other problems since birth. Characteristics of pain control, frequency, duration, average number, date of last crisis. Past and current medical treatment, surgeries, transfusions, medications, and allergies. Presence of venous access, catheters, and joint replacement. Growth and development issues. Consultation with the patient's primary care provider to determine disease control, including complete blood count. Determine if the antibiotic prophylaxis is indicated before any form of tissue manipulation, which could create a bacteremia, is performed because the patient is highly susceptible to infection. A stress reduction protocol is necessary to prevent precipitation of a sickle cell crisis. Implement a comprehensive preventive program to minimize oral infection and control oral disease risk factors. Avoid long, complicated dental appointments by maintaining good oral health with frequent preventive care appointments with the dental hygienist. Use local anesthesia with a low dose of vasoconstrictors to avoid intravascular occlusion of the red blood cells. Moving on to polycythemias. Polycythemia implies an increase in the number and concentration of red blood cells above the normal level. There are two categories of polycythemia, primary and secondary. So polycythemia vera, primary polycythemia. The cause. Polycythemia vera is a neoplasm caused by a genetic mutation increasing the sensitivity of bone marrow cells to erythropoietin, resulting in an increased production of red blood cells. Blood viscosity increases, affecting oxygen transport to tissues. Clinical signs and symptoms. Average age at diagnosis is 60 years. Increased bleeding risk with spontaneous bleeding of the gingiva. Bruise easily, resulting in submucosal petechiae and hematoma formation. Risk of fatal and non-fatal blood clot formation leading to heart attack, stroke, and pulmonary embolism. Migraines, vertigo, fatigue, purplish or red areas on the oral mucosa, gingiva, lips, or tongue. The treatment of primary polycythemia: chemotherapy, phlebotomy, blood drawing to reduce the total volume, particularly the red volume of the blood, low dose aspirin, less than 100 mg daily, as an antiplatelet. Dental hygiene treatment considerations. Thorough review of the medical history due to the increased risk of bleeding, bruising, cerebral vascular accident, and myocardial infarction. Consult with a hematologist and a primary care provider about disease management and patient's blood test results, especially hemoglobin and hemocritic. Careful attention to oral self-care and preventing maintenance is required to maintain good oral health. Carefully monitor bleeding and monitor clotting during and following instrumentation. Provide careful post-operative instructions for early identification of bleeding that does not stop after applying pressure. The next one, secondary polycythemia. It is also called erythrocytosis, an increase in the number of red blood cells. Increased red blood cell production can result from hypoxia due to chronic obstructive pulmonary disease, cyanotic heart disease, emphysema, tobacco smoking, and residing at high altitudes. Bleeding tendencies may be partially controlled by control of gingival irritants. Okay, moving on. Blood disorders of white blood cells. Disorders may occur because of the decreased leukopenia or an increased leukocytosis of number of white blood cells. Neutropenia. Neutropenia, a decrease in the total number of neutrophils, results when a cell production cannot keep the pace with the turnover rate or when there is an accelerated rate of removal of cells as in certain disease statuses. So, etiology of neutropenia. Defects in the myeloid cells possibly due to genetics. Secondary neutropenia may develop in the following conditions: alcohol abuse, autoimmune diseases, HIV, AIDS, chemotherapy, radiation therapy, folate, vitamin B12 deficiency, infection, or bone marrow transplant. Signs and symptoms of neutropenia. Oral stomatitis and lymph node enlargement may be present in patients with neutropenia, resulting from defects in myeloid cells. Frequent severe or unusual infections such as pneumonia. Diagnosis of neutropenia. Moderate neutropenia, 500 to 1,000. Severe neutropenia, less than 500. When values drop below 500, even normal microbial flora in the mouth can cause infection. Dental treatment considerations for neutropenia. Thorough review of the medical history is essential. Consultation with the primary care provider is necessary to determine if neutrophil count is at a safe level. Antibiotic prophylaxis may be needed. Okay, another type of white blood cell. Lymphocyte Opie Nia. This is abnormally low number of lymphocytes in the blood. The etiology of Lymphocyte Opie Nia. Acquired Lymphocyte Opie Nia may be caused by protein energy malnutrition, AIDS, chemotherapy, radiation therapy, or infection disease such as hepatitis, influenza, and tuberculosis. Hereditary lymphocyte Opie Nia may be associated with inherited immunodeficiency disorders. Some signs and symptoms: pilar, bruising, petechiae, mouth ulcers, and the dental treatment is the same for neutropenia. Let's go on and talk about leukocytosis. That's another white blood cell. Leukocytosis is an increase in the number of circulating white blood cells caused by inflammatory and infectious states, trauma, exertion, and other conditions. The most extreme cause of leukocytosis is leukemia. Leukemias are malignant neoplasms of immature white blood cells that multiply uncontrollably. Cancer cells located within the circulating blood and in bone marrow infiltrate into other body tissues and organs such as the spleen and lymph nodes. Leukemias can be acute, such as acute lymphocytic leukemia, or chronic, such as chronic lymphocytic leukemia. Oral manifestations may include bruising and bleeding of the gingiva. Moving on to platelet disorders. Platelet functions in the clotting system. Disorders include abnormal increases and or decreases in number of platelets and platelet dysfunction. When the number of platelets decreases, the risk for bleeding increases. Risk of bleeding increases when platelet count is below 50,000. Thrombocytopenia, decrease in platelets. A low number of platelets may be caused by decreased production in the bone marrow. Bone marrow depression may be due to drugs such as hydrochloroside used to treat high blood pressure and acetaminophen, infections like HIV and hepatitis, or blood transfusion. If severe, a platelet transfusion may be necessary. Reactive thrombocytosis, overproduction of platelets. Overproduction is due to another disorder. Causes include acute infection, chronic inflammatory diseases, iron deficiencies, and certain cancers. It's not usually an increased risk for thrombosis. Platelet dysfunction. Acquired platelet dysfunction. Cause of acquired platelet dysfunction includes cirrhosis, systemic lupus, erythematosus, and certain drugs. Hereditary platelet dysfunction. Dysfunction may occur because of a disease such as von Willebrand disease, a coagulation disorder. Moving on, bleeding or coagulation disorders. Blood clotting or hemostasis is the body's mechanism for stopping bleeding from injured blood vessels while preventing intravascular clots, which can cause serious health problems. The three main processes of blood clotting include constriction of bleeding vessels, activity of platelets, and activity of blood clotting factors. A history or suspicion of a bleeding problem requires careful evaluation before treatment can be started. Spontaneous bleeding occurs as a small hemorrhage into the skin and mucous membrane and other tissues and appears as petechiae or purpura. People with bleeding disorders have the tendency to exhibit spontaneous bleeding and moderate to excessive bleeding following trauma, surgical procedures, or dental hygiene therapy, including non-surgical instrumentation. Oral findings suggestive of bleeding disorders. Early signs of systemic conditions frequently appear in the oral soft tissues, and clinical examinations may identify these changes. Referral for medical examinations may lead to a diagnosis and treatment of serious disease. Laboratory blood tests may provide essential information for safe and effective dental hygiene care. Oral soft tissue changes observed in patients with blood diseases are not necessarily exclusive to systemic blood disorders. It is necessary to recognize change in a previously healthy patient or an apparently exaggerated response in a patient being examined at an initial appointment. Findings suggesting a blood disorder include the following: gingival bleeding spontaneously or excessive bleeding on gentle probing, history or of difficulty in controlling bleeding by usual procedures, history of bruising easily with large ecchymoses, numerous petechiae, marked pilar of mucous membranes, atrophy of the papilla on the tongue, atrophic glossitis or magenta tongue, angular stomatitis, persistent sore or painful tongue, glossodema, acute and chronic infections such as candidiasis that do not respond to usual treatment, severe ulcerations associated with a lack of response to treatment, exaggerated gingival response to local irritants, sometimes with characteristics of necrotizing ulcerative gingivitis, ulceration, necrosis, bleeding, and pseudomembrane. Vascular fragility is increased. Petechial and purpura hemorrhages appear in the skin or mucous membranes, including the gingiva. Disorders of coagulation. Abnormal bleeding can be due to acquired drug-related or hereditary factors, including disorders of the coagulation system or platelets and or the blood cells. Acquired bleeding disorders, vitamin K deficiency. Vitamin K is essential in the synthesis of prothrombin and clotting factors VII, IX, and X. Food sources of vitamin K may be found later. Vitamin K is also produced in the alimentary tract by intestinal bacteria. Excessive exposure to antibiotic therapy or prolonged gastrointestinal disturbances may affect vitamin K production. Liver disease. Most clotting factors are produced in the liver. When the liver is not functioning properly, production of clotting factors may be altered, and it may occur in cirrhosis. Renal disease. Erythropoietin is produced by the kidneys, which is involved in the stimulation of red blood cell production in the bone marrow. Bone marrow disorders impact red and white blood cells production. Drug-related acquired bleeding disorders. Anticoagulation drugs. Following are the examples of some common medications. Antiplatelet drugs such as aspirin, nonsteroidal anti-inflammatory drugs, and Plavix. Anticoagulants such as warfarin and heparin and Coumadin. Corticosteroids, chemotherapy. Hereditary bleeding disorders. At least 30 hereditary coagulation disorders exist, each resulting from a deficiency or abnormality of a plasma protein. Hemophilia. Hemophilias are the oldest known hereditary bleeding disorders caused by low levels of complete absence of blood proteins essential for clotting. The etiology results from mutation or deletion affecting the factors VIII or IX gene. Hemophilia is an X-linked recessive genetic disease. The defective gene is located on the X chromosome. Thus, the disorder occurs primarily in males. The treatment. Most patients do well with appropriate medical management involving the administration of drugs to decrease bleeding or the infusion of platelets or plasma-containing clotting factors. Effects and long-term complications. Bleeding and bruising for minor trauma vary depending on the severity of the disease. Bleeding into the soft tissue of joints, hemarthrosis, or knees, ankles, and elbows begins in very young with severe hemophilia. Hemorrhage into the muscles or intramuscular hemorrhage is accompanied by pain and limitation of motion. Bleeding from the gingiva is common and more extensive when periodontal infections are severe. Management of uncontrolled bleeding. The hematologist should be consulted prior to performing dental procedures with a risk of postoperative bleeding, including subgingival debridement and scaling. In someone with mild bleeding disorders, the clinician should implement the following. If clotting does not occur within a few minutes, apply digital pressure to the area with sterile gauze. If needed, local hemostatic agents can be applied, such as absorbable gelatin sponge, absorbs about 3 to 5 days. Medical attention required if bleeding is not controlled. Dental hygiene care plan. Preparation for clinical appointment. Certain blood tests may be needed prior to treatment and should be documented. Prothrombin time. International Normalized Ratio, INR. Ideally should be measured within 24 to 72 hours of an invasive procedure. Indications for screening and pre-appointment tests. When the patient reports a history of bleeding problems, clinical examination reveals signs of bleeding disorder, patient is being treated with anticoagulants, chemotherapy, or corticosteroids. Patient history, medical history view. Question patients specifically regarding bleeding after previous clinical and surgical procedures, such as tooth extraction. Question about blood or plasma transfusions, as individuals who received them prior to 1990 are at risk of Hep B and C, as well as HIV. Patients with bleeding disorders may have many emotional stresses related to the condition, including ongoing anxiety. So it's important to understand the patient's psychosocial situation. Medication review. The primary purpose of the drug and potential side effects needs to careful review in a current drug reference guide. A variety of drugs and herbs may be factors in increased bleeding. Herbs and supplements associated with increased bleeding are in the box here in this chapter. It is recommended to carefully review any herbs and supplements the patient is taking, which could be associated with an increased risk of bleeding, and to discontinue for at least a week prior to receiving invasive surgical procedures. Patients taking Coumadin, heparin, or medication for long-term anticoagulation, such as aspirin, may need special consultation. The most common side effect of both warfarin and heparin is hemorrhage. Hemorrhages may present as gingival bleeding or submucosal bleeding with hematoma formation. Cancer chemotherapeutic agents may secondarily induce profound thrombocytopenia, less than 20,000, or neutropenia, less than 500. Antithrombotic agents such as aspirin and clopidogrel Plavix alter the ability of platelets to stick or clump together and form a clot. So the dental history review. Discuss previous dental care and perceived treatment needs when developing the current care plan. Risk assessment. Early prevention of oral disease should be initiated at a young age, including regular professional preventive care, meticulous oral self-care, appropriate use of fluorides, and pit and fissure sealants. Consultation with physician and hematologists. Consultation with primary care provider, hematologist is necessary to obtain and complete accurate information. Anticoagulant therapy is seldom discontinued for most dental treatments because the risk of intravascular clot formation is greater than the risk of hemorrhage. A joint policy advising healthcare providers who perform invasive and surgical procedures to contact the cardiologist and discuss patient management before discontinuing antiplatelet drugs have been developed here. Consult primary care provider, hematologist, and determine whether antibiotic prophylaxis is required. In inherited bleeding disorders, many procedures require factor replacement therapy immediately preceding the dental appointment and request reports of current blood tests. The examination. Use a pre-procedural chlorhexidine mouth rinse to reduce the bacterial load prior to beginning the treatment. Radiographic imaging. Films or sensors can cut and press on the mucosa membranes. Exercise care and placement to avoid bleeding and hematoma. The dental and periodontal examination can be conducted once a consultation with the primary care provider or specialist has assessed the need for antibiotic prophylaxis or pre-treatment to prevent bleeding. Treatment care plan. Oral self-instruction, nutritional counseling, preventive aids including fluoride treatments, remineralizing agents, and sealants, prophylaxis or non-surgical periodontal therapy, restorative care, referrals as needed, and continuing care recommendations. The treatment, nutritional assessment and counseling are recommended for caries control and periodontal health. Provide patient education to enhance the oral self-care at the initial appointment and reinforce each session to minimize bleeding during instrumentation. Spontaneous oral bleeding problems can partially be controlled by the elimination of oral inflammation and infection. A soft toothbrush is indicated. If patients indicate using a power brush, proper demonstration of technique is necessary. Choose the appropriate interdental aids to teach the patient to prevent tissue injury. Patients with limited manual dexterity can benefit from adaptive oral hygiene aids. Stress reduction protocol. Local anesthetic. Use local anesthetic with a vasoconstrictor. Infiltration injections are preferred. Block anesthesia, especially for the inferior alveolar and the posterior superior nerve blocks, increase the risk of bleeding. In inherited bleeding disorders, preoperative infusion to prevent bleeding is necessary for block anesthesia. NSPT require a consult with a medical provider to ensure patient is management properly to prevent an emergency. Post-operative, monitor to ensure bleeding has stopped. Frequency of continuing care. Frequent appointments can aid in keeping the oral tissues at an optimum state of healthy to help prevent the need for complex or lengthy dental appointments. Documentation. Review or update the medical history thoroughly. Document extra and intraoral examination findings. Note treatment planning considerations. Note consultations with other health professionals. And reference any difficulties with bleeding control during the appointment.